volunteer.
Okay, it's 12:30, and so I was told I had 45 minutes, and so I practiced this ahead of time, and I got about 46 minutes. So I'll have to talk fast, I may go a little bit over time. But if I'm not able to answer all your questions before we have to quit, I'll be happy to stay around and you can ask them for me, okay? So the topic that I've been assigned is ENT for primary care providers. Can you hear me okay, or is it reverberating? It's okay. So first of all, I have no financial relationships with ineligible companies to disclose. And these are the topics that I was asked to cover. And if you look at them, you can imagine that I can't cover all of those in any detail in 45 minutes. So what I'm going to do is sort of hit the high points based on my experience in having primary care doctors refer patients to me in about a year and a, about 15 years, spending a half day a month with family medicine residents in their clinic, looking at the kinds of ENT problems they see. So we're going to start off by talking about rhinitis, allergic vasomotor, and then chronic sinusitis. The one thing you'll notice a little different than in your brochure, I moved otitis media from being with sore throats up to eustachian tube dysfunction. Because most of the eustachian tube dysfunction you see is going to be connected with otitis media in one way. And then we'll talk a little bit about sore throats. And I also have to apologize. The reason I'm sitting on this stool is I had a total knee replacement 6 weeks ago, so standing up is not the most comfortable thing. So I hope you don't mind. So I was asked to do scenarios. So the first scenario I have is that we have a 32-year-old woman who presents to your clinic in May, early May, and that she has complaints of nasal obstruction, headaches which have occurred intermittently over several years. So what's the differential diagnosis that comes to mind immediately? Allergies, right. It's early May, that's allergy season, at least for us in Portland, I'm sure it is out here for you. So March, April, you're going to get trees, and then starting May, June, you get grasses. And so that's the first thing I'm going to think about. So what questions do we need to ask her? So the questions I like to ask, thinking of allergic rhinitis, are, does she have a lot of sneezing, running itchy eyes, itchy nose or throat, decreased smell in any way, and then what kind of nasal discharge does she have? Is it clear, gray, thick, watery, or does it have color to it, green, yellow, brown? Then I want a little bit about past history. Has she ever been told she has nasal polyps? Has she ever had sinus infections? Has she ever had nasal surgery? What treatment has helped her symptoms, or what hasn't helped her symptoms? And a little bit more about the headaches. Is it pressure, pain? Is it over the maxillary teeth? And a few other questions are, is there seasonal variation, which kind of helps us determine whether it might be perennial or annual? So the other thing when we talk about vasomotor rhinitis that I think about is they do not tolerate strong odors. Things like perfume, aftershave, cigarette smoke, environmental smells. I remember having 2 or 3 patients who worked in a grocery store. And I don't know if you ever thought about it, when you walk down the grocery store, particularly where there are soaps and things, the smells are really strong in there. And so these people working in the grocery store had a lot of problems. Do they have trouble drinking beer or wine or fresh newspaper or stress? I had a medical student, every time exam time came, he'd come in to see me. If they have an upper respiratory infection, does that make their symptoms worse? And then what about asthma? We heard an excellent lecture earlier this morning about asthma. One thing that Dr. Money didn't really talk a lot about was, does aspirin or NSAIDs make their symptoms worse, or do they have hives or breathing problems with that? Then you have to think of substrate triad, nasal polyposis, asthma, and allergy to aspirin or NSAIDs. So next thing I'm going to do is examine the nose. Now maybe you all do this. First of all, I like to examine and see what the nose looks like. I look at the turbinates, see how much room there is in the nose, if there's any discharge I can see. But how many of you, if you have a patient come in with a nasal complaint, routinely spray the nose to decongest them? Anybody do that? I would encourage you to try that because you will be amazed at how much better you can see in the nose and make a better diagnosis. And this is the one thing when I would spend time with the family residents, it was the one thing that I told them, because I got to do one every time. It was the one thing I really did. And you can get Afrin. I always used the 15 cc bottle. That was the smallest we could get, I think. I don't think there's a 5 cc. And that works just fine, but the problem is we can only get single use. And so at the VA, we use this little atomizer. It's a little lure lock. You put it on a 2.5 cc syringe, put your Afrin, or like for us for nasal endoscopy, we mix it 50-50 with xylocaine. And what it does is the foam plugs up the nose, and then it just atomizes what you're putting in there. And it will anesthetize all the way down to the larynx. So it's very quick, very easy. So it's something for you to consider. But if you don't have that, just take and use a regular syringe and squirt a little Afrin in there. But then wait for 5 minutes. Don't look immediately. Then you want to look at the nose again. You want to see how much the swelling decreased. You want to see if there are any deviations in the septum that might be obstructing. Is there any discharge or blood? Where is it coming from? Is it coming over the top of the inferior turbinate from the middle meatus? Are there any polyps or masses that are obstructing the airway? Now, I'm not going to give you the diagnosis right now. I don't know, I guess we can't really turn the lights off very conveniently, but I think you can see on the left something, a mass in the nose, and then we'll look at the right. Okay, so now we're going to examine the nose, and I'm trying to make this in a chart to make it a little bit more clear. For allergic rhinitis, the turbinates are going to be swollen. They usually kind of have a pale bluish appearance, and they a lot of times look a little bit edematous. Vasomotor rhinitis is very much similar, but maybe not quite as much swelling, and the inferior turbinate is really usually big, and it's the main obstructing part of it. In sinusitis, you'll see a little bit more erythema in the turbinates and the mucous membrane. Now, allergic rhinitis, I know that maybe 20–25% of patients with allergic rhinitis are going to have polyps. But if you see polyps, there's going to be pale masses that are going to be coming usually from the middle meatus. They can extend all the way down to the floor of the nose, and sometimes they get large enough they actually come out the anterior nostril, which kind of grosses everybody out. Vasomotor rhinitis, you usually don't see polyps. Sinusitis, sometimes we see polyps, but it's not a main characteristic. Discharge. With allergic rhinitis, it's usually clear and watery. Vasomotor rhinitis is similar, but it may be a little bit more gray, and it may be a little more thick and tenacious. In chronic sinusitis particularly, usually it has some color to it, yellow, green, brown, and it usually is coming out of the middle meatus or the upper part of the nose and runs down along the floor. And if you look through the mouth, you'll see it on the posterior oral pharynx. Septum can be crooked or straight in any of the three. So, the one on the left is a nasal polyp, quite characteristic. So this would be the inferior turbinate here. This is the septum, and this polyp is coming out of the middle meatus. It's almost down to the floor of the nose. This is the natural ostium of the maxillary, the ostium to the maxillary sinus, and you can just see this strand of mucopus coming down there. And that's what you kind of want to look for. If you're going to make a diagnosis of sinusitis, particularly chronic sinusitis, you should see some pus. Now, if you don't decongest the nose, you may not see it, but you usually will see that. Okay, what are the diagnostic studies you need? Sinus x-rays? We've pretty much given up on sinus x-rays. Even when that was the only thing we had, they were hard to interpret, and once we got used to using CT scans, you get so much more information that we usually go to that right away. Now, allergic rhinitis, I don't get CTs on most of those patients unless I see polyps. And normally I would not get a CT scan, even in the presence of polyps, until after I had treated them probably at least 6 weeks to 3 months with corticosteroids, nasal spray. If I still see polyps, and or they're really obstructing, I would get a CT scan. Vasomotor rhinitis, the only time I would use that I'm sure you've had this experience, patient coming in, they're absolutely convinced they have sinusitis because they got pain over their forehead or they got pain over their maxillary sinuses, and you will not convince them any different. So sometimes I actually get a CT scan, show up the sinuses are totally normal. Sinusitis for chronic sinusitis, particularly CT scans, you just have to get them. MRIs, rarely get them. If you have a suspicious mass in chronic sinusitis, or you're worried about intracranial extension, you might want to get an MRI. Allergy testing. So we usually didn't have allergy testing really available that much. So I tended to treat patients, and sometimes I would use their response to treatment as my diagnosis. But sometimes the patient wants to know what they're allergic to. So intradermal allergy testing is the gold standard. I mean, that goes back even before I was in medical school. More recently, prick test has become more common, and I think that's what most allergists use because it's quick. And it's pretty close to as good as intradermal. A RAS test, that's a blood test, which is convenient because you don't have to stick them a bunch of times. But it's expensive, and so I tend not to use that very much. We did use it at the VA a little bit because we had a panel. So if you have a panel of what's common in your area, you might consider using a RAS test because it's quick and easy. Intradermal food testing, that's really controversial. Most medical allergists would not think that was worthwhile. I worked in Singapore for several years, and my boss there did a lot of allergy, and he really believed in this. He convinced me that there was probably something to it, but it would not be something that I would really recommend. Vasomotor rhinitis, sometimes you might want to do allergy testing to distinguish between allergic rhinitis and vasomotor rhinitis. And sinusitis, normally you don't use it. So, management. For allergic rhinitis, I usually start off with oral non-sedating antihistamines, which is usually Claritin or loratadine, and a nasal steroid spray. That would be my first line of treatment. If the patient has a lot of polyps, particularly if I see that on CT scan, I might use a tapering dose of prednisone for 2 to 3 weeks, and sometimes it's interesting. Nasal polyps will just magically disappear, and they can smell again. But then the problem is, within 2 months, they start coming back, and then they can't smell, and then they want another dose of steroids. And I don't like giving steroids every 2 or 3 months. I haven't gone as often as giving them twice a year, but I feel uncomfortable with that. So for vasomotor rhinitis, antihistamines usually don't work very well. You can try them. Ipratropium nasal spray will sometimes help these patients, but the other thing is to find out what really makes them stuffy. Sinusitis, occasionally we'll use nasal steroid sprays to try to reduce inflammation. Antibiotics, no for allergic to vasomotor rhinitis. Sinusitis, definitely, you will want to use them. Saline irrigation, same things. Very good in chronic sinusitis, sometimes even acute sinusitis, but I'm pretty careful about using too much sinus irrigation in the presence of acute sinusitis. Surgery, allergic rhinitis, no. The one place we do use surgery for vasomotor rhinitis is to reduce the size of the inferior turbinate. And over my 50 years in ENT, we've gone through all different kinds of things. Freezing them, out-fracturing them. I used to take the inferior turbinate bone and break it out. Now, most of the time, well, in fact, I just talked to one of my colleagues, and she says what she still uses is just a microdebrider. And you stick it, you make an opening, and then just stick it in, you microdebride out all the soft tissue, but leave the mucosa intact. So turbinate reduction does work sometimes. In Singapore, they just lop out the whole thing, which works really well, but don't do it here, because in Singapore, it's very humid, and I think they get by with it. Particularly out here, we might get by with it in Portland, but out here where it's dry, you'll get crusting and recurrent infection and what we call empty nose syndrome. So don't lop out the whole turbinate. Sinusitis, definitely surgery will possibly be indicated. Some other adjuvant therapies for allergic rhinitis, allergy avoidance. Again, in Singapore, our most common allergen was dust mites. 80% of ours were dust mites. So we used to do things like put plastic on their mattresses and on their pillows, have them wash their pillows and things frequently. Here, if you have somebody who has seasonal allergies, sometimes putting a filter and on air conditioning, staying inside will help. Intranasal antihistamine nasal sprays, I don't use them very much, but they do work well for seasonal allergies. And the reason that they're nice is they do very well for nasal discharge, and you can use them on demand. Nasal steroid sprays, you all know, you have to use them regularly, and that was what Dr. Mahoney was saying about asthma. If you just do it whenever you feel like it, it won't work. But LTRAs will work for seasonal allergy, and just use it when you're really plugged up and having a lot of discharge. Immunotherapy. Again, subcutaneous immunotherapy is sort of the gold standard. Again, that goes back long before I was in ENT, and we still do it. About 25 years ago, we started getting reports out of Europe that they were using sublingual immunotherapy. And everybody in the U.S. poo-pooed it, but in about the last 10 years, you'll start to see some stuff in the literature about it now. And it does work. I don't think it's quite as effective as subcutaneous, but if you know what your allergens are, it definitely works. And what I have read is about 70% effective, where you would expect the subcutaneous immunotherapy to be closer to 90%. The big advantage is the patient can do it at home. And it might be something, if you're in primary care and you don't have an allergist close, you might want to go somewhere and learn how to do this, because it might be valuable for your patients if you see a lot of allergic rhinitis. The last thing that's relatively new, and again, Dr. Mahoney talked about this for asthma, is dupilumab, which has been approved for severe polyposis. She mentioned rhinosinusitis. My understanding, and I've not used this, but my understanding from my colleagues are that they really reserve it for severe polyp cases they've operated on. And I mean, the worst thing for us when we do endoscopic sinus surgery for polyps, 6 months later they're back with another nose full of polyps. And those are the type of patients that are to help. Now, what do you think the disadvantage of that is? Yeah, monoclonal, that means big money, $30,000 a year. And so they really reserve that for just special cases. Antibiotic managed sinusitis, acute sinusitis, and I came early to hear the antibiotic talks. After hearing them, I thought I was going to have to scrap this whole slide, but I went and talked to them afterwards, and we weren't too far off. High dose amoxicillin, augmentin, or ceftriaxone, and I use it for 2 weeks. And when I talked to, I've forgotten their names already, but when I talked to the 2 antibiotic people yesterday morning, they said there's really no evidence or any recommendations one way or the other how long you should treat chronic sinusitis. And I like to use it, for acute sinusitis, I usually use it for 2 weeks. Probably can get by with 10 days, but the argument is that sinusitis destroys the function of the cilia. And if you don't have ciliary clearance of the ethmoid and the maxillary sinuses, it fills up with mucus and the bacteria just love to start back up again. And so it takes about 3 weeks for those cilia to start to function again. So that's my reasoning behind it. The one thing I did learn yesterday morning was, I had never realized, augmentin, I always use BID, and he said that the amoxicillin loses half-life every hour, and if you do it twice a day, that there is really no amoxicillin after about 6 or 8 hours, I think he said. And when I talked to both of them afterwards, they said, if you're going to treat my family, do it TID. So that was something I learned, and something that you might want to consider if you're going to use augmentin. Probably ought to use it 3 times a day rather than twice a day. Recurrent acute sinusitis, again, I tend to go longer, 3 to 4 weeks. And here's where I really use saline irrigation. Yes, sir?
Which dose? You're talking 875?
875, yeah. Yeah. I suppose you could get by with 500 if you're going to use a TID, but I probably still go with 875. And also on recurrent acute sinusitis, I would add nasal steroid sprays to try to reduce inflammation. For chronic sinusitis, as a doctor being referred to, we see patients that have been treated over and over with multiple antibiotics, and what we usually do is what we call maximal medical therapy. We culture the nose as best we can. We try to get it out of the middle of the anus to get as close as we can to what it is. We do a CT scan, and usually you'll find multiple sinuses involved. Then we use targeted antibiotics for 2 to 4 weeks. We'll put them on a tapering dose of prednisone for 10 to 14 days. We use nasal steroid spray. May or may not use an antihistamine depending on whether we think there's any allergy. And for sure, saline irrigation. And we treat them for at least 6 weeks. And if they're not getting better, that's when we would start to recommend surgery. Okay, so the one thing that, just one minute, I have to turn that on. This morning, Dr. Mahoney talked about patients that it's important to see how they use their inhalers. And so when I get somebody who tells me that, oh, nasal steroids don't work, I said, well, how long did you use it? Well, I used it for 5 days and that wasn't getting any better. Or I used it whenever my nose got stuffy. So you gotta take the time to explain that to them. Also, if most of us don't take time to show them how to use it here. So we have an example here. Click on the little yellow arrow. It's not working?
My asthma. They said they'd fixed it, but it didn't make any difference at all.
Well, sometimes doctors make mistakes. Anna, you need to try twice as hard to fix them. Are you using your inhaler?
All the time. Go through one a week.
Are you sure you're using it right?
Do I look like an idiot?
No. Why don't you show me how your inhaler works?
So it's a good idea to see how they're using it. Okay, any questions about that? Okay, we'll move on to talking about eustachian tube dissection and otitis media. And I divided this into children, adults, and elderly. I'm sure you all remember where the eustachian tube is. It comes off the anterior inferior portion of the middle ear. It goes down inside, actually about 1/3 of its bone, which is a little more than this shows, and about 2/3 cartilaginous, ends up in the nasopharynx at the opening of the eustachian tube orifice. So the lining of the eustachian tube is the same as the lining of your nose. It's respiratory mucosa, and so if you get a cold, that lining is going to be swollen as well. So here's the case scenario. 25-year-old mother brings her only child, a 3-year-old, to your clinic because her mother, or the grandmother, you always want to listen to grandma, told her she thought the child's speech development was delayed. The mother thinks the child was just shy. She can hear the father come in the house after work and responds to people talking to her. She did have several ear infections from age 6 months to 2 years, responded to antibiotics, and she's not had any for 6 months. So you examine the ear, and this is what you see. Now, how would you describe this tympanic membrane? Now, the way I would describe it, it's got a nice conal light. And we all told in medical school conal light's normal, right? But the conal light is due to the concavity of the eardrum. And if you have a retracted eardrum, even if there's fluid, whoops, what happened here? Even if there's fluid in the middle ear space, you'll have a nice conal light. Where you lose the conal light is when you get acute otitis media and the eardrum bulges. Then you lose that. So, what I would say, this is kind of dull amber appearance. The other thing though, notice the malleus. Now if I represented the malleus handle with my hand, and that's the normal position, and I retract it like this, my wrist is supposed to look more prominent. but my hand looks shorter, right? And that's what you get here. You get a very prominent short process of the malleus and a foreshortened malleus handle. And that tells you that that eardrum is retracted. So I didn't ask you what the diagnosis was, but the diagnosis is otitis media with a fusion. So what are your options? You could observe them. Sometimes, I'm sure you've read, frequent gum chewing, eustachian tube massage. How many of you ever heard of eustachian tube massage? And how are you supposed to massage the eustachian tube? I mean,
No.
yeah, but where? I mean, you'd have to stick your finger behind the soft palate and up into the posterior coin and massage the. And I don't think.
You make the patient do it.
Oh, you make the patient do it. Okay. So anyway, so when I first started, we always used decongestants and antihistamines, but there are a lot of papers in the late 70s, early 80s showed that that was no use. One of the things that did come out in the 80s was that somebody got smart enough and they cultured all of the fluid in these ears. And they had the same kind of bacteria in as acute otitis media. They said, okay, if we treat them with a month's worth of amoxicillin, maybe they'll clear up. And it did work in about 20-25% of the patients. Quite honestly, I think we were just buying time. And this is not recommended anymore. It's more time. So, the management now would be to observe them for at least 3, and some people now say 6 months before you would do a myriadotomy tubes. If you have a otolaryngologist referred to as popping tubes in 4 to 6 weeks after an otitis media, that's not good. You shouldn't do it that soon. So observe them for at least 3 months. I would recommend that you get a baseline audiogram and or tympanogram, which I think is helpful. Now timing, what I mean by that is, I change my recommendations a little bit depending on the time of the year. If I have a patient who comes in like May or June and has got fluid in the ears, maybe been there for 2 or 3 months, what I'll usually say, let's wait until September or October to put the tubes in. Unless it's a young child that I'm really worried about speech. And the reason I do that is because a lot of those patients will clear up over the summer with nice weather. And so I tend to be much more, I don't tend to put tubes in as soon. But if that eardrum I showed you, I can almost guarantee you that will not clear up over the summer. That's just thick blue fluid in there. But if I see somebody in November and they've got fluid like that and they've had it for 3 months, I would probably go ahead and put tubes in. So for you, I think referring them for myriadotomy and tubes after 3 months, 3 to 6 months is indicated. What about an amnoidectomy? There was a paper came out of the University of Washington probably in the mid-80s, and they recommended that you do an amnoidectomy when you do tubes. Well, the problem was that study was done in 4-year-old children that were 4 years old or older, and what happened was that a lot of people then translated that to 1 and 2-year-olds. I never liked doing an adenoidectomy that young, unless they had an obstruction. You know, if they had OSA, I would. But just for otitis media, I would prefer to put in 1 or 2 sets of tubes. Usually, if you put in a set of tubes, let's say a year and a half, the tubes will stay in for about a year. And by now, they're 2.5 to 3. They probably aren't going to have tubes put back in. I would say maybe 20 to 25% are going to have a second tube without it if you don't do an adenoidectomy. So I usually didn't do an adenoidectomy the first time around. Now part of my problem was that I had a lot of cleft lips and cleft palates in my practice, and so those children had to have more tubes. Recurrent acute otitis media, we know that tobacco smoke and daycare attendance are predisposing factors. Thing that's interesting with COVID and kids not going to daycare, my friends who are in pediatric ENT said the number of tubes and patients they see for that has really dropped off in the last 2 years. Breastfeeding and pneumococcal vaccines will also help decrease the incidence. I usually recommend treating each attack with antibiotics. I usually, if it's recurrent attacks, I'll go to the second line drugs, usually augmented. And then if you're having attacks, 3 to 4 attacks every 6 months, or 5 to 6 in a year, I would consider putting in a set of tubes just to try to break that cycle. Next case, 45-year-old businessman on a business trip to the East Coast a week ago. He had an upper respiratory infection. Coming back, he had pain when they were landing. The pain resolved over 46 hours, but he had a persistent fullness and decreased hearing in the ear. And you can see the bubbles here? Now, what I would do is I'd have him try to pop his ears while I watch the eardrum, see if he can force any air out of the station. He might not be able to. So how do you handle this? Well, you can wait. Most of those will clear up in 4 to 6 weeks. You can have them pop their ears, and what I usually do is I usually put them on Sudafed, and I say pop your ears, try as hard as you can, at least 4 times a day. And a lot of times I'll say, but it hurts. But I tell them, if you can stand it, after you do it 2 or 3 times, usually the pain will go away. So I use an orally congestant. Only if I really get pushed would I do a myringotomy, and I hardly ever do a myringotomy tubes for this. Now, some of you may have heard of eustachian tube dilatations. It doesn't make sense to me, but what they do is they put the patient to sleep, and particularly, I don't think I would do it in young kids, but they put a little tube with a balloon on it up through the eustachian tube, and they blow that up to try to dilate the eustachian tube. Now, you're not going to dilate the osseous part, so about 1/3 of it is not going to do any good. The only place I can see where this might be useful would be a patient who had a lot of otitis media as a child and now keeps getting recurrent otitis media, particularly if it's unilateral. And maybe they got some scarring in there, and you can dilate that. The last thing I want to mention is patch eustachian tubes. How many of you have ever heard of patch eustachian tubes? Yeah, so it's not very common. It's usually people who've lost a lot of weight, 20, 30 pounds, and they'll come in and they'll tell you, I can hear myself talk. Very annoying. They say if I lay down, it goes away, or if I have a cold, it's better. And what it is, normally the eustachian tube is closed like this, and then the tensor palatini and the levator palatini muscles open the tube, and the air goes back and forth. But this one, it's open all the time. And so when they talk, the sound goes right at the eustachian tube. Very annoying. These patients, it doesn't happen very often. You want to refer those to your local otolaryngologist, let him deal with the complaint.
2 quick questions. Like on the tissue that's in the eustachian tube, you said what tissue is like, does
Yeah.
it have cilia? I just thought, are there cilia in the soft tissue in the eustachian?
Yes, they are.
And the second question,
Yeah.
what about the use of stents for chronic eustachian tube dysfunction?
Well, so that's the one thing, that was tried about 25 years ago, and it was a disaster. People tried to put cytolactic stents down through the middle ear into it, and I had a friend who was at a big children's hospital, and he said he did 20 cases, they all got infected, he had to take them out, and so no, that doesn't work. And then I think somebody came up with the idea of dilating. I'm not sure how well that's going to work in the long run. Any other questions about that? Okay, so elderly, 76-year-old male presents with a 2 to 3 month history of decreased hearing on right side, one side, no recent URI, no other symptoms. You examine his nose, oral cavity, neck, all normal, but he has a retracted, immobile tympanic membrane. What do you worry about? So, the thing you need to do if you see this, you have to rule out a nasopharyngeal lesion or mass. Even younger than 70, I would say even down 50s, 60s, 40s if you have unilateral. But I'm a little bit prejudiced because in Singapore, we saw a lot of nasopharyngeal carcinoma, and they would usually present with either neck node or serous otitis media. So it's important that you have somebody look at the nasopharynx in a patient like that. Other causes of ear pain and pressure, lifelong eustachian tube dysfunction. You can also have idiopathic. Otitis media show up, particularly in older patients. We see this in the VA a lot, and I don't know why. We can never figure out why they get it. They don't have allergies, so I don't have a good reason for it, but it does occur. Also remember, you can get referred pain from the oropharynx. Cervical arthritis can cause pain in the ear, as well as temporomandibular joint syndrome. So this just shows a nasopharyngeal carcinoma obstructs the eustachian tube. And as I said, nasopharyngeal carcinoma, they usually present with a neck mass or serous otitis media. So those are the things that I worry about. Now, the one thing that's interesting, here in the US, most of our nasopharyngeal carcinomas are squamous cell. In Singapore, they were undifferentiated, so they respond a lot better. The cure rate was much better there. And that's, so people who are of Chinese descent, Southeast Asia is where we saw a lot of it. So Southeast China, Hong Kong, Singapore, and then Chinese diaspora in Southeast Asia had a high incidence. So I don't know if any of you ever feel this way or not.
Yes.
I've had some friends that say they actually like it when people do this, then they know ahead of time.
You have to charge it for deprogramming.
Okay, sore throat. Children, I divide this into children and young adults, adults and elderly. So you see a 6-year-old boy in the emergency room, fever of 38.5 degrees centigrade, complains of severe left-sided sore throat, he has trouble swallowing, he's actually drooling a little bit. He complained of a sore throat about 5 or 6 days ago. It seemed to improve, but then last night it really got a lot worse. And he comes into the emergency room, and this is what you're seeing. Here's the uvula, here's actually the tonsil, and then you've got this mass pushing everything over. So, peritonsillar abscess, signs are unilateral tonsillar swelling, pushing the tonsil to the midline. Trismus, they have trouble opening their mouth, and uvula deviation. Management. So this has changed. The gold standard, again, is incision and drainage of the abscess, and that's what I was always taught. Somewhere in the late 80s, we were presenting a patient in Grand Rounds one morning, and we had a visitor from Southern Oregon, an otolaryngologist. And he says, I don't drain them anymore. He says, what I do is I aspirate them and put them on steroids. Well, putting people on steroids with an infection was an anathema for us, and we thought he was crazy. But he says, I've only drained 1 or 2 abscesses in the last year. And so we started trying that and just aspirating using a 18-gauge needle, aspirating the pus, putting them on steroids, and starting them on antibiotics, obviously. And you may have to re-aspirate them in a day or two, but there's probably about 10-15% of the patients that you do an ID. You've got to go back in and open up your wound anyway. And now the literature, this is becoming more and more accepted, just to aspirate the abscess, put them on antibiotics, and put on steroids. Particularly if I see a lot of cellulitis and swelling around, sometimes, or you can't get much pus, or there's no pus there. The steroids, it may just rapidly improve. Now, patients with infectious mono. So, infectious mono can look like tonsillitis. To me, there's a little bit different appearance. It's this kind of whitish appearance is a little different than what you see with acute tonsillitis. So if you see something like this in the emergency room, I'd recommend you test them for infectious mono. And if you do, again, I put them on steroids. In about 24 or 48 hours, they're almost gone. And one of the reasons that we started doing this was, we had a 6-year-old came into the emergency room. The resident, I was on call, the residents called me and they said, Dr. Smith, we've got this patient who's really having trouble breathing, huge tonsils touching the midline. We think we ought to admit her. While they were talking to me, she went into respiratory arrest and they had to intubate her. And so we actually did an emergency tonsillectomy the next day, just to give her an airway. And, but then we found out that, if we had these patients like this, if we caught them early enough, put them on steroids, they very rapidly will decrease. And I don't think I've done an emergency tonsillectomy since we started doing that. Other concerns, unilaterally enlarged tonsil, concern for malignancy. In children, you think of lymphoma, or in adults, squamous cell carcinoma. Yes, ma'am?
I'm sorry, how much steroids do you usually put them on?
Depends on the age.
Oh, okay.
Yeah. So I would just look up and say, prednisone and whatever the dose would be for the appropriate age.
Like a 5-day course?
Oh, so usually I only use it for about 24, 48 hours. And sometimes I just use IV dexamethasone.
Oh,
I just use it for a couple of days, and then if they're better, then I stop it.
okay.
Yeah. Yes?
On your treatment at Quincy, I've seen post-20 cases of it.
Yeah.
I only had to refer one because they obviously had airway obstruction.
Yeah.
On the other 19, I had no problem with just giving them 3 decadrons.
Yeah.
And put them on clindamycin for 7 days, and all of them cleared without aspiration.
You didn't even aspirate it? Really? Okay. So, for you who cover emergency rooms and see those, may not need to ask me. For me, pus sitting there. Good. Indications for tonsillitis really haven't changed much, but the thing that has changed, when I was a resident, I would say at least 80% of the tonsillectomies we did were for infection. Now, it's more like 20 or 25%. Most of it's done for obstructive sleep apnea. But for the indications for infection, 7 episodes in 1 year, 5 episodes in 2 years, 5 per year for 2 years, or 3 episodes per year for 3 years. Obstructive sleep apnea obviously is an indication. Unilaterally large tonsils, if we see those, we take them out because we worry about squamous cell, particularly in adults. And then, so the big question is a paratonsillar abscess. If you drain a paratonsillar abscess, we always used to recommend in 6 weeks to do a tonsillectomy. But then we started finding out that only about 20 to 25% would get another one. So I would always sit down and talk to the patient and say, look, you got a 20 to 25% chance of getting another abscess. So if you want to wait and see if you get another one, I think that's fine. If you do get another one, then I would recommend you have your tonsils taken out. Post-tonsillectomy complications. Unless you're in an emergency room in a remote area where your ENT guy's far away, you probably don't need this, but we usually divide it into immediate or delayed, and most of the ones are delayed. The ones that are the most serious are about 4 to 6 days. My last 5 years at OHSU, I was an expert witness on 5 cases of patients that died, 3 cases that died post-tonsillectomy. All bled at about 4 to 6 days, and I think what really happened was they aspirated blood, and that was the cause of the death. It wasn't the actual blood loss. But anyway, if you're in the emergency room, one of the things that the residents just a couple months presented, which I'd never heard of before, they are now using nebulized tranexamic acid in acute tonsil bleeds. And they found in the literature it shows that about, they reduced the ones that have to be taken to the operating room by about 73 to 30%. So it might be something if you're alone out in a more rural area, something you might try to see if it'll help stop the bleeding. Otherwise, I usually just use it, if you can get it cooperative enough, take the cotton ball, soak it with ephedrine or something like that, and just put pressure on it, and then try to use a silver nitrate stick to cauterize it. Otherwise, we have to take it to the operating room. Adults, I'm almost done. 35-year-old man presents in your clinic with a 2-month history of left sore throat, which has become progressively worse. He is a non-smoker and only a social drinker occasionally. He has a right 2-centimeter firm mobile cervical node in level 2, and when you palpate the base of his tongue, there's a mass on the left base. 35 years old. What do you think it's going to be? You have to be concerned about carcinoma, obviously. So, first thing to do, get an FNA of that node. It's positive for squamous cell. You then refer them for a pandiendoscopy and biopsy. They will test it for HPV, and the HPV test is positive. HPV is now responsible for the majority of oropharyngeal, that's tonsil and base of tongue carcinomas in the U.S. The good news is it's got a better prognosis than squamous cells that we see later on. But here's the point that I want to make for you is it's important that boys get vaccinated for HPV, not just the girls. And so I really encourage you to try to talk parents into having their boys vaccinated. It's just like cervical carcinoma. But that's been a huge change in the last, I would say, 10 to 20 years that HPV is causing these carcinomas. Okay, so this is the last case. It's an older man. This is actually a patient of mine at the VA. 70-year-old white male. He presented with a complaint of pain behind his right ear for the past 4 months. He had no other symptoms, but he lost about 10 pounds of pain, 10 pounds of weight, which should have been a bit of a red flag for me. He was a smoker, moderate alcohol user, but I looked at his ear canal is normal, the eardrum is normal, and then, by the way, this is what an eardrum should look like. I nice long malleus handle, translucent eardrum. You can actually see the long process of the incus through there. Anyway, it was all normal. The rest of his head and neck exam was normal, but I was a little bit worried. But I didn't have anything else to go on at that point. So what I did, I don't know what you all would do, but the one thing I never want to do on a patient like this is tell them to come back if they feel worse. So I made an appointment for him back 4 weeks. Still have the pain behind his right ear, no other change in his symptoms. His ears still look normal. His oral cavity and oral pharyngeal exam were normal. But when I felt his neck, and the other thing I'll point out, if you don't do this, if you're feeling the neck for nodes, particularly in the upper third or half, really get your thumb down under that sternocleidomastoid. If you just go like this, you're going to miss a node that's anything less than 2 or 2.5 centimeters. But get your thumb underneath there and really press underneath the sternocleidomastoid, which is what I did on him. Oh, and I felt this mass. So then I took another look, and sure, with a little more careful look, I noticed he had a little edema at the superior pole of his tonsil, and when I palpated it, there was a 1.5 centimeter firm mass there. And indeed, he had a squamous cell carcinoma. So my point with this is, if you see pain, I thought, when I first saw it, I thought, well, maybe he's got cervical arthritis. It's just referred pain from cervical arthritis. But always keep in mind referred pain from the oral pharynx that will go to the ear. Temporal mandibular joint syndromes will do that. One of the most common complaints or calls that we get from parents after a tonsillectomy in a child is, my child's got an ear infection now. And it's just referred pain from the acute tonsillectomy. So particularly, I should have been a little bit more careful at my first visit when he had that pain in his ear, even though I didn't see anything, to look a little bit more carefully in the oral pharynx. So anyway, that's the point. Okay, any questions? So I still have 10 minutes for questions? Okay. I wasn't sure whether that was finishing time or my talk finishing time. Yes, sir.
I have a question regarding recurrent sinusitis and chronic sinusitis. Numerous inflammatory conditions, abscess of the teeth, gout, rheumatoid, other things have been linked with an increased risk of cardiovascular problems. Is that true with chronic sinus conditions as well?
Not that I'm aware of. I'm not associated with that. And it may be because a lot of our chronic rhinosinusitis are in younger patients, 20s, 30s, 40s, rather than the older group. I don't know. I certainly have seen that in the literature. Yes?
For patients with chronic allergic rhinitis that has tried multiple, like Allegra, Zyrtec, and whatnot, Flonase, everything doesn't work for them. What are your thoughts about using steroid injections?
That's a good question. Where are you going to inject it?
In the arm?
Okay, so you're using long-acting steroids in the arm. And they love it, right?
Most of them do.
That's the problem. So yes, and that was, well, what we used to do was we would inject it into the inferior turbinate. It worked great. But then there were 2 or 3 reports people got blind after they injected. So then people were afraid to inject the inferior turbinate. I mean, if I did it, I would start injecting and pull the needle out very quickly, so hopefully it wasn't staying in any vessel. It was pretty rare, but the problem with that is once it gets reported, if you do get a patient with blindness, well, you don't have a leg to stand on when it goes to court. So most people don't. But the bigger question is for you, I worry about doing that long term. In general, most ENT people would recommend against that. But I know a lot of people do it. And in the primary care literature, is it recommended? Not to me.
It used to be, and then they kind of cut it out.
It used to be.
Some people still kind of do it like every other year, a really bad year.
Yeah.
The patient comes in, nothing else works, I may give it 40, you can't.
Yeah.
That's it.
Yeah.
That's it.
Yeah.
The concern I had heard about it previously was that the Kennewick lasts 3 months. Normally it tapers down within 1 out of so many thousand patients, you get an abrupt steroid withdrawal. They go in steroid crisis to the emergency room. The ER doc says, "Are you on any meds?" They go, "No." and the emergency room doc isn't looking for the problem.
That's
So-
interesting, that's interesting, I've not heard about that.
And the acute steroid withdrawal can be life-threatening.
Yeah.
And that's difficult, again, if you end up in court. You know, you were treating their allergy, their hay fever, and they died because of your treatment.
So I guess the question would be then, do you want to try some of the new monoclonal antibodies? I don't know that they recommend it for polyps, and Dr. Mooney said for chronic rhinosinusitis, and I know my colleagues use it some, but the other thing I wanted to mention, I can't remember who it was, whether it was Dr. Mahoney this morning or one of them yesterday, we're talking about using afro-nasal spray, and the comment was, well, they would use it longer than 3 days. I don't really worry about 10 days, actually. It's if they're gonna use it for like 2 weeks and then just keep using it, that's when I start to worry about it. I mean, you'll occasionally get patients who, they get so hooked on it, I had patients come in and use it for 10 years. But the big problem is the rebound phenomenon, and so I don't like to do it. But if I have a patient who's got acute sinusitis, I don't mind using it for 5 or 6 days, or even, like I say, up to 10 days. Because what you're trying to do is reduce the swelling and inflammation so that the nose can drain. That's the whole key to sinusitis, is getting the nose, the sinus to clear that mucus out of there. And I was saying when I talked to the two gentlemen yesterday morning, what we used to do for chronic sinusitis, particularly maxillary sinusitis, where you get an x-ray and you got a sinus that's full of pus, or you see pus coming out of the natural ostium, we used to irrigate those with saline. And we would do it once a week. And you irrigate them once a week for 4 to 6 weeks, you can a lot of times clear it up without any antibiotics. Nobody does it anymore. My residents don't even know how to do a sinus irrigation like that. Anybody ever seen it done? It's kind of brutal. So what we used to do is we use cocaine in the inferior meatus. They go through the lateral wall of the inferior meatus, and it goes through really easy. And then you just wash it out. But then about 5% of the people would faint. So then somebody said they started numbing up just here in the canine fossa and using an 18-gauge spinal needle and just go through the thin part. And that actually worked pretty well, except you get this needle, and then to get it through there, you have to take a little hammer and go tuck, 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 tuck. And so a lot of people didn't like that. But it didn't hurt.
Especially the crunch when it goes through.
Yes, ma'am.
So I recently read something about improper usage of nasal steroids leading to septal perforation. How often do you see that?
I had not seen the association with that. Now, I guess the thing that I would worry about in that situation is the patient. So I always tell the patient, when you use your atomizer, you put it in your nose, aim for your eye, like this, so it goes up and lateral. Now, if they keep pushing it against the septum, what might happen is, they do that, it dries out the mucosa, they get crusting, and then they pick the crust, and then, they can get a perforation from that. I would think that would be the most likely. So perforations in the septum are usually due to surgery, or chronic nasal picker. We actually had a lady once who, you get a crust and it annoys you, and you pick it, and then you get another crust and you pick that. This lady literally picked off the whole end of her nose. She had some psychological problems, obviously. But one of my colleagues made a mistake of trying to reconstruct it, and then she picked that off. So, but from what you're saying, I would think that most likely it could be that they're spraying against the septum, and it's affecting the mucosa, and then they get crusting, and then you pick at it that way.
I did find a handout about proper usage, and it says just what you said, to make sure they point
Yeah,
this
yeah,
way
yeah.
and not this
Yeah,
way.
yeah.
So I
And
have
definitely
that.
not on the neck.
I also asked about your cocaine use.
Yeah.
You would?
I asked
Yeah, exactly, yeah,
I've got a guy that has enough septum.
yeah. From cocaine, yeah, that's the other thing, that's very common. And the other thing is, we always worried about cauterizing the septum for, 90% of your nosebleeds are going to be small vessels on the septum, and we usually use silver nitrate to cauterize. But you gotta be careful about cauterizing on both sides. I will occasionally, but I just cauterize very lightly. But don't do deep cauterization with a silver nitrate stick on the septum, because that can cause perforation. The problem is, what happens is if, the cartilaginous septum depends on its blood supply from the mucosa. So if you destroy the mucosa on both sides of the septum, then the septum the cartilage will get necrotic, and that's where you get your perforation. And the other thing you worry about, if you see a perforation in an older patient, if it's got a lot of granulation tissue, you always worry a little bit about being carcinoma. Sometimes you'll see lymphomas. There's a newer, I forget the exact name of it, but it's what we used to call Wigner's granulomatosis. There's a type of lymphoma now that gets in the nose, and that sometimes will cause perforations as well. Okay, any other questions? Well, thank you very much for coming. Even though it may have not been the most up-to-date thing like the fetal surgery this morning, I hope that maybe you got something that you could use.